I'm Bronwyn Fredericks, and I'm an Indigenous woman, a Gurri Murri woman from southeast Queensland. And I wanted to acknowledge country that we're all on, wherever people may be coming in from today. I know that we're all in different time zones, but we all are coming in from someone's land. And I acknowledge the elders of the past and the present on whose land you're on and you're zooming in from tonight. I do note we've got people from outside of Australia as well, and I welcome you here as well today. So it's great to have so many people here for this webinar this evening. I just wanted to kick it off with a little bit of reflection that in the past week we've had the National Allyship Summit for the health sector, and I encourage people to have a look at the video for that event. So the National Allyship Summit for the health sector. The video is available online, and you can get that at Croakey News as well, and along with all the live tweeting that was done by journalists from Croakey. So I am the co-chair of Croakey News, and I really want to warmly welcome everybody here this evening, the participants, the panel members, and the sponsor as well, the Australian Physiotherapy Association. Please note that all the housekeeping details are in the chat, along with the taglines or the hashtags for people to use tonight if you're doing social media. That's all in the chat, along with people's contact or taglines. I wanted to remind people, and if you don't know, but if you do know, remind you that this webinar is part of Croakey's Medicare 40 Years project, the 40th anniversary year of Medicare in Australia. It does provide an opportunity for us to, or Medicare provide an opportunity to critically look at health reforms and health discussions in Australia, especially with the federal election coming up into 2025. We've already had 3 excellent webinars on, and they included addressing oral health inequalities or inequities, improving healthcare for First Nations people who were incarcerated, and the National Scope of Practice Review, which I attended. It was very interesting on that. Please remember that you can check back on the social media in regards to news on those 3 webinars, but also the videos that were available, because they are all recorded, as this one will be tonight. This webinar is about better care for people with knee osteoarthritis. So it is, I hope, of great interest to people who are on here tonight. We've got some fantastic speakers who are going to address the issue and provide some information and updates. I do want to remind people that on Thursday, the Australian Commission on Safety and Quality in Healthcare will release an updated national guidance on the best treatments for this common condition that affects many, many Australians, but indeed many, many people from across the world. So it will be an important document. The 2024 Osteoarthritis of the Knee Clinical Care Standard has a new section that highlights the importance of culturally appropriate communication, resources, and healthcare delivery to support Aboriginal and Torres Strait Islander peoples living with osteoarthritis of the knee, and encourages clinicians to reflect on the cultural safety of service provision. I think often it's not, just my personal reflections here, it's not thought of in regards to Aboriginal and Torres Strait Islander people, an issue of Aboriginal and Torres Strait Islander people. As some people in our communities are living longer, and when I say some people in our communities, in Aboriginal communities, are living longer, it also means there's greater incidence of osteoarthritis of the knee. The standard points out factors to consider when providing care of Aboriginal and Torres Strait Islander peoples, including taking a person-centered collaborative approach to ensure that the interventions are tailored to individual needs, and also preferences of care. It's not just about any old care, it's preferences for care in terms of the options. Engaging Aboriginal Torres Strait Islander health workers and practitioners as part of a patient's multidisciplinary team. And I know that may not always be possible in terms of there may not be Aboriginal Torres Strait Islander health workers or practitioners available. And encouraging the involvement of persons' carers, family members, friends, all their circle in regards to aspects of care, including decision-making and planning. So this webinar will inform related journalism by Croakey, and live tweeting of this event will happen. So I need to make sure you're aware of that. And an in-depth report by Croakey editor and journalist Marie McInerney will also take place after the event. Another Croakey live webinar focused on pending 1-year anniversary of the Voice referendum will be held in September. So please look out for that one as well. It will be hosted by myself and co-chair James Blackwell. So look out for that one in September. And material information about that will be coming up soon. And now it's my great pleasure to hand over to Dr Elizabeth Deveny, CEO of the Consumers Health Forum of Australia, who has really kindly agreed to moderate this discussion, recognising the importance of centring consumers' experience and expertise in these discussions. Over to you, Elizabeth.
Thank you so much, Professor Fredericks. That's very kind of you. And thank you for a lovely start to our session today. So yes, in the chat, folks, you'll see all the rules and regulations, but we're hoping to have a lively chat. So for those of you that already put which country you're from, joining from, that's fantastic. I only count about 10 or so, and there's 48 of us on the call. So feel free to be the next person to put in to say hello and where you're from. We also hope that this will be fairly interactive. So the plan is, in a moment, I'll introduce our panel. The panel will answer some questions or give you their thoughts about this new standard and why it's important. But we want to hear from you. What do you want to know? We have a little time at the end where we can have a conversation. So if you've already had a look at the standard and you've got a question, put it in the chat. As they're talking, if you think of something, put it in the chat. So that at the end, when we've got that time together, we've got some good questions to look at together. If not, I'm sure we'll be able to find some ourselves because we're all good at asking each other questions. But really, your opportunity today is to hear from these amazing experts and ask them what they think about the implementation and the shape of this current new standard. I'm also very keen for you to consider using the emoticons too. It's very hard when you're presenting and you can't see your audience. So one way to let people know if you like what they're doing is to use the reactions button. So if you're on your phone, it can be a bit tricky, but if you've got a laptop and you click on reactions, it will show you a whole lot of different ones. I'm going to click on the ta-da now, and you'll see that's come up next to me. So what I want to do to check that your button is working, if you go to reactions, pick any reaction you like and just click on it, and let's see if we can get them working. I'll give you a second to find the reactions and pick one out and press the button. Everyone have a go at pressing the button and seeing if you can get those reactions happening for you. If you've got your, great, I can see a thumbs up, saw a party hat or something like that, some hearts, fantastic, and claps. Thanks, Marie. Oh, a phone. That's very fancy, Jane. Thanks, Ali, everybody, for your thoughts. And during the session, feel free to use those reactions also in the chat, as well as putting your thoughts into the chat, because that gives also the people doing the presentations a sense of, did you like something? Did you not like something? Someone put something in the chat and you like their idea, give them a thumbs up or a heart to show that you support them too. That way we all get the opportunity to share together. So yes, my name's Elizabeth and I'm the Chief Executive of Consumers Health Forum. We're the national peak body for health consumer peaks. So we have about 80 organisations who are our members, and we work with our member organisations as well as more broadly with consumer leaders and community members around Australia to understand what it is they want the health system to deliver for them, and then to do our best to advocate that government takes account of that in its policy settings. I say do our best because we're not always successful. And I'm joined tonight by a terrific panel. We have Dr Phoebe Holdenson Kimura, who's a medical advisor from the Australian Commission on Quality and Safety in Healthcare. She's a GP based in Sydney, and she's working in policy and medical health and health professional education. So welcome, Phoebe. We've got Danealle Gilfillan, who is an advanced practice physiotherapist and the project manager of HCF's best practice pathways in knee osteoarthritis research, which is a project that's being done with Canberra Health Services. We have Scott Willis, who's the first Indigenous man to be elected as the national president of the APA, which is the physiotherapy peak. Pellerman. He's the co-director of a multidisciplinary clinic in Burnie on the northwest coast of Irwita, Tasmania. He has experience with public, primary care, private practice, rural practice, Indigenous practice, aged care. What he hasn't done, I don't know, and occupational health sectors as well. And we have, we also have Nigel, who's a specialist knee surgeon based in who works to reduce unnecessarily knee surgery. But unfortunately, he can't come with us tonight because of some other commitments that have come up suddenly. So he has an article in Croakey, which is entitled "The Surgeon Explains Why He Works Hard to Avoid Knee Surgery for His Patients." There will be a link in the chat to that, and encourage you to have a look at that, because it talks about patients who are referred to surgeons can sometimes benefit from non-surgical. Thanks for popping that in the chat there, Alison. They can benefit from non-surgical interventions and the importance of looking at addressing some of the barriers to better care pathways. Okay. So that's our terrific panel. I'm sure you'll agree with me that they're great. Again, send them some love anytime you like. And you can see Nigel's article there, so you can cut and paste that, pop it somewhere on your phone or your laptop to look at when you've got a moment. So we're going to start with you, Phoebe, if that's okay. And I would like you to just tell us about the standard, why we need this kind of standard, and what difference you're hoping it'll make.
Thanks, Elizabeth. So evidence of low-value osteoarthritis care, specifically around high rates of knee arthroscopy among older Australians, with significant geographical variation across Australia, pointed to the need for the first clinical care standard targeting knee osteoarthritis at the Commission. So in 2017, the first osteoarthritis in the knee clinical care standard was released, following a comprehensive development process that involved topic experts and consumers with wide stakeholder consultation and peak body endorsement. And many of you will be familiar with that clinical care standard. So now 7 years on, we've seen that arthroscopy rates have dropped by 47% in Australians over the age of 45, but we know that we're still doing too many. And this is just one of the many focuses of the clinical care standard. And this week, we will be introducing the updated osteoarthritis the knee clinical care standard and indicator set, which have been carefully revised to ensure alignment with the new evidence, contemporary international guidelines, and advances in person-centered care. So the updates also target current priorities for improving osteoarthritis care through reducing low-value care, improving non-surgical management, and reducing unnecessary imaging, which I'll talk about in a bit more detail. So importantly, the quality statements are intended to apply to all healthcare practitioners and spaces that are providing care for people living with osteoarthritis of the knee. So that means medical practitioners, allied health professionals, and nurses. And that really is to promote consistency in assessment, management, and communication with people living with OA of the knee. And what's really significant as well is that we have the support and endorsement of all the peak bodies which represent these professional groups and key stakeholder organizations. So, you know, we have the APA, of course, the Australian Orthopaedic Association, the College of Surgeons, and many of the other peak bodies. So that's really, really great. So the standard continues to affirm that knee OA can be confidently diagnosed with a clinical assessment. And so there's a stronger focus on clinical diagnosis and avoidance of unnecessary imaging, particularly MRI, CT, and ultrasound, and that if imaging is warranted in the case of an atypical presentation, then erect X-rays are the preferred option. We also highlight the importance of self-management support, and the quality statement around self-management and physical activity also talks more around optimal nutrition and weight management, because we know that these are all are vital for everybody living with knee OA. So I think, you know, since 2017, we've seen very good uptake of the clinical care standard, particularly in multidisciplinary clinics based in hospital outpatient settings. And we've seen a reduction in knee arthroscopy rates in line with the evidence. And so what we'd like to see now is for the clinical care standard to continue to be adopted across all healthcare settings which are providing care for people with knee OA, whether that's in a GP's surgery, a physiotherapist room, private specialist consultations, and across all of Australia. And that's our main aim this time around.
Thanks so much, Phoebe. So you've set a bit of an aspiration there as to what you want the standard to achieve. How are you going to measure that? How will you know if it's achieving what you want it to achieve?
That's a great question. So I guess at a local level, the services can use quality indicators in the standard to measure improvements in care and outcomes. And we have seen particularly those multidisciplinary settings in hospital outpatient departments that I referred to earlier, using those quality indicators regularly to see how their service is delivering care and patient experiences and outcomes of those. I guess at a national level, our main measure is arthroscopy rates, and we do hope to see continue to see that coming down. And then I think at an individual patient or consumer level, what we're really wanting to see is for everybody living with osteoarthritis the need to be provided that same care pathway where early on they're given the right messaging about what's happening with their knee. Everybody is offered non-operative management at the time of diagnosis and supported to access that well. And then if they go on to need to consider surgical management, then that is explained well and carried out in a really consistent way as well.
Fantastic. That's really helpful. So thank you, Phoebe. We'll come back to you later on when we get back to our discussion. Meanwhile, to all of you, Phoebe raised some really interesting points. You might have some more questions for her. Now is your time while you're thinking of your question. Pop it in the chat, and then if people like that question, give it a heart or a thumbs up or an okay sign, so that when we get to the end, we know that's one of the most important questions for us to talk about. So I'm going to throw to you now, Danealle, and I'd really love you to talk to us about the work you've been doing with the Better Care Pathways for patients in the ACT.
Yeah, thank you so much. I'm really grateful for the invitation to speak to this forum. So I am a physiotherapist. I work as an advanced practice clinician in emergency, but previously I've worked in public health screening clinics where we use a physiotherapist to assess patients who've been referred to a surgeon in the public system before they see a surgeon to evaluate whether or not they're ready for surgery. But the problem we had was we had growing waiting lists for our surgeons, and waiting lists had blown out for non-urgent patients. They were waiting up to 800 days to see a surgeon. And if they weren't screened, sometimes they were slipping through, and the surgeons would see them and then they'd say, well, have you tried physio? Well, you better go away and do that. And this is after they've waited 800 days. So that was a real problem. So I was very fortunate to be joined by some academics from the University of Canberra who put together a grant application to the HCF Foundation, who have helped support us with some finance to investigate what are the pathways that we could implement to address these long waits and patients who don't need to be on waiting lists. So we've been running this project for about 18 months, and I was brought on board as the project manager. And we've basically evaluated this screening process where we look at physiotherapists working at top of scope practice, seeing patients referred by GPs before they see the surgeon. And what we've done is redirect those who haven't tried physio, but only after they've had a really patient-centered assessment, which consists of about a 45-minute conversation, an individual assessment, and discussing with the patient what the best care pathway for them looks like, and then making sure that they're enabled to go access that. So that's also required access to alternative care pathways. And one of the pathways for knee arthritis is a program called GLAD, which stands for Good Life with Arthritis, which has come out of Denmark. And we were really lucky in Canberra that the public health system also funded GLAD programs, which really enabled us to provide an alternate pathway. So we've sort of looked at what's happened, and we've had some really great success when we've had patients come through the screening clinic. They've only waited about 40 to 50 days, and we've redirected about half the patients who come into our system, which has taken pressure off the wait lists to see surgeons. So they're now only seeing about half as many patients, and the waiting times dropped down to under 90 days. And the patients they're seeing are ready to discuss surgery. So overall, we've basically identified what a really efficient pathway of care looks like in the public health system. And so that's been a really rewarding project to be involved in. But essentially, it's been grounded in the Australian Commission on Health, Safety and Quality's NE-OA standard. So if we didn't have that standard, we really wouldn't have legs to stand on for our project.
I love the pun at the end. Thanks for that, Danealle. I hope others liked it too. Well done. 50% less people and a reduction in waiting lists. That's fantastic, because if you're in knee pain, it's really, you can't stand in the kitchen sink to peel the potatoes. You can't walk the dog or even take the bins out. So do you think this approach should be available more widely? Can you see it translating or scaling up?
Look, one thing that's been really interesting as part of our research project was we did interviews with stakeholders in knee arthritis at every level. We asked patients what they thought. We asked GPs what they thought. We asked physios, even the executives within the health system, and our surgeons. And everyone agrees that this pathway is a really good patient-centred pathway of care. The problem is really the funding barriers. The GPs tell us that they struggle to provide access to non-surgical management for their patients, and are sometimes just referring them to a surgeon for advice on what to do because there's blockages in the system elsewhere. So I think that what we'd all really like to see is knee arthritis considered chronic disease and managed at the community primary care level as chronic disease first.
Yeah, fantastic. I'm sure there'll be people with questions for you too. There's a couple coming into the chat now, so you can have a look at those, and we will come back to those at the end of the session. But I'm going to come across now and talk to you, Scott. And as a clinician and a very amazing advocate for the physiotherapy discipline and for wider health reform generally, you sit on lots of committees. What's been going on in your mind as you've been listening to this discussion? What are the key calls to action?
Yeah, thanks, Elizabeth. And look, it's great to be here tonight and listening to a couple of the experts really explain it quite well, or what some of the issues are. But I think if we look at it from a systematic point of view, I think we've been very spoilt with Medicare, with a public funded medical system, which has been really, really amazing. And if you look at it from a worldwide system, it's one of the best. But I don't think it's fit for purpose anymore. I think, it's coming up to, it's in our 40th year birthday. We've had 20 years of allied health funding anniversary as well. But I think we can do better. And I think the public, the consumer and the taxpayer really thinks that, we need more efficiency. We need more ability to be able to have a system that's fit for purpose, that's contemporary, that's really future focused. And if you have a look at the all the reports, including the Medicare Task Force report, we want to try and get to a bit of a more of a wellness model rather than a sickness model. And that's what Medicare was really designed to fund. And that is, if you got sick, you could get access to that care that you required by the appropriate person. But what we're seeing now is what Danealle and also Phoebe has just explained, is that what we're actually doing is enabling surgical interventions that have got their place. And we're not saying here tonight that you shouldn't actually have a total hip or a total knee replacement. What we're saying is that there are some alternate pathways that may actually be a better care for you at that time in your process. So you might just have to have access to a different type of clinician, and that might be through non-surgical interventions such as physiotherapy, such as dietetics, such as maybe an exercise physiologist or any other type of allied health practitioner. So I think what it's really demonstrating is that our current system, our Medicare system, is actually funding surgery, but it's not actually funding probably some of the high level care, such as non-operative management of osteoarthritis, such as osteoarthritis of your knee and osteoarthritis of your hip as well. So I think this really highlights that we need to change. We need to actually go through some true health reform processes that really demonstrates and really funds what's really classified as that high value care.
That's fantastic, Scott. And you mentioned high value care, and there's often the comment made that high value care is often underfunded and low value care is overfunded. It's not ideal. What do you think about that, and how do you think we change that mindset of governments and funders to actually thinking about the value when they think about the dollar sign?
Yeah, I think it comes back to to Phoebe's point. We've got some clinical care standards, but what we really need to do is incentivise some of this prevention and also some of the non-operative care procedures that are demonstrating that we're getting probably better outcomes, better health outcomes for the consumer. It's more efficient, and sometimes it brings less risks as well. So I think if we look at it, the overall package, I think we really need to prioritise some of our funding mechanisms. And Danealle touched on it just a minute ago, that a lot of general practice people that are in primary healthcare pretty much refer their patients to a surgical intervention, because that's where the funding mechanism is. If there was an equivalent or even better funding and mechanisms for non-operative procedures, I think the access to care would actually improve. The access to non-operative mechanisms would actually improve as well. And I think what you'll see Australia-wide, especially in the rural and remote areas, is access to high-value care would actually improve. It would increase. Your health outcomes would actually improve. The health spend would actually decrease, and probably some of our high-risk patients might actually not require the surgical interventions that they probably thought they would need.
That's fantastic. Now, I'm just letting our wonderful panelists know there are quite a few questions in the chat. You might like to have a little look at those and see the ones that I'm likely to ask you, because I'm going to do a quick little summary, and then I'm going to come back to you and ask you about some of those questions. So feel free to do that. I'm going to do a little reflection on what I've heard you say and what it might mean for health consumers. Again, really encourage you to all add your own thoughts in there too. And it has come out in the chat in a couple of the conversations, but there's a big issue around affordability. So, and actually whether it is surgery where someone's being charged, a large out-of-pocket fee, versus physio and other allied health support, could be OT, all kinds of things, pain management, you name it, pain meds and so on. All of these things cost money. We know that the cost of living crisis, as people are calling it, is very significant in Australia. And so people being able to afford whatever it is, being on the public waiting list is not maybe ideal, especially if you're going to be there for a couple of years, my goodness. But eventually it's kind of, at least the first part will be free. So you may be able to afford to do it. That made me think about access to, and really love what Danealle's doing, but my mind went straight away to like rural and remote environments and how you could virtualize that, whether that's even possible in community. But if this is a good option, and again, for people who certainly might not want to be off country or don't want to wait a long time, how we can make sure this kind of an approach is available to everyone, not only those people who are lucky enough to live in that kind of more urban environments. Prevention is always, better than, I say, Medicare. So what can we do to keep people well and, make sure they don't need to get to the point of any really kind of drastic interventions like surgery? And how do people tell the difference? And someone in the chat talked about, whether people would want to see a physio rather than a doctor, whether people want to not have surgery. Some people have fixed in their mind, my friend had this issue, they got surgery, they got better. The only thing that will work for me is surgery. And we change that conversation with your GP, with the community. And that is really about education for the community to understand what it means to have osteoarthritis in your knees, what best practice really looks like nowadays, not what it might have been 20 years ago, but what, your mum might have had something done to her knee surgically. Doesn't mean 30 years later you'll need the same procedure. So getting that communication really happening is important. And I did think a little bit about, this came out a little bit in particular, I think when you were talking to Neil maybe think about clinical governance. So when we have these really long waiting lists, one of the things I get very concerned about is clinical governance. Who is managing that patient while they're in a waiting list? Because often the GP and primary care chick, love my GP colleagues, feel like they have handed the patient across when they've sent the referral. So this person's going to have a procedure now. So maybe they don't talk to them so much about exercise or about weight loss or whatever, meditation to manage pain. It's kind of in their head, they're kind of over there. But of course, for the hospital, the patient's not there yet. And they may be doing nothing really to support the person, especially if they don't have your, magic pathways in place, Danealle. So you've got someone who's not really being engaged proactively, perhaps with their primary care folks, not being engaged proactively with the hospital environment, whose situation might deteriorate, and across the country are really poor at actually checking on people on waiting lists to see if they're deteriorating. Sometimes when they get to the top of the list, they're no longer good candidates for surgery for a variety of reasons, and we haven't explored anything else with them. And again, if they feel in their heart that the best thing that can happen to them is that they have surgery, and then we say, actually, you can't have surgery, that can have significant impact for that person, not only for their knee, but also for their feelings of hope and their mental health and well-being. So clearly there are a lot of conversations yet to have. And, Scott, you're right, is about, Medicare needs to be thought of differently, and how we can explore ways where it can support communities and individuals, particularly where people are experiencing a lot of health disadvantage for a range of reasons. How do we make sure that Medicare wraps its arms around them and make sure that they can get the care they need, which we're saying may not be surgical care. So that's, shout from the rooftops. Doesn't have to be surgical care. And we can hopefully then get people to understand that there are all kinds of options available to them, not just surgical options. Now, there are quite a few questions in the chat, and we've got a good, 15, 20 minutes, which is fantastic. So we're going to go through those. I'm just going to whip up the top, so just bear with me. I don't know how, but somehow I managed to cut 2 of my fingers. So I've got Band-Aids on them, which means now I can't touch my phone. When I use the mouse, everything doesn't work properly with Band-Aids. Modern technology, right? So I feel very clunky. My children would say I am clunky with technology anyway, but I'm really clunky with technology today. Great. So I've got a question for you, Phoebe, which is about, is there any evidence about the public's understanding of things like the better care pathways for knee OA? Do you know if people know about this?
I mean, my experience just as a GP, having seen patients now in the primary care setting for about 10 years, I do think that public opinion's shifting a little bit, particularly away from surgery. Finding that I say to patients, oh, surgery might not be the best option for you, or we should definitely explore other options first. And that message is increasingly, I think, well received, and people themselves are wanting to avoid surgery, which I think is really good. I think what we're still finding, quite challenging, and that's something that we've highlighted as a new feature of this clinical care standard, is how we're talking about knee OA. And gosh, I think in the community, but also amongst, some health professionals, we're still using language like bone on bone, wear and tear, oh, your joint's stuffed, all those sorts of dreadful phrases, which I think really gives people those health beliefs that make them think that, you've just got to grin and bear it. You've got to wait the time, and then eventually you'll need surgery, and that, puts people in a very passive position. And what we know from the evidence is that actually being proactive and getting support to get back and move your joints, knowing that joints are designed to be loaded and nourished by movement, is really, really powerful message. But I mean, I had a medical student sitting in with me today, and I asked him, oh, so what do you know about knee OA? I was sort of interested as to know what they're learning. And he's in second year. And he said to me, oh, it's pretty much degenerative. It's bone on bone. It's wear and tear. And I thought, oh gosh, we've still got a while to go. So I think people, are more and more open to that pathway that we're really trying to promote in the clinical care standard. But I think it's the language and the health beliefs that we've got to continue to work hard at.
Yeah, thanks, Phoebe. Danealle, I'm going to come to you now because there was this question. Thanks, Gwen, for your question about the public believing that only the doctor is the person you should see. The doctor is the expert. I noticed Angie said that wasn't an issue. Do you think it was? Did you have a patter or were there an email that went out? What got the people thinking about the fact that this was a good thing and that they would trust your clinical judgment even though you didn't have an MBBS?
We've had the Advanced Practice Physio Screening Clinic operating in Canberra now for over 10 years, and the general practitioners are really behind it, and there's a growing acceptance among patients. But with our project, we actually interviewed the patients, and they just told us they wanted someone who knew what they were doing to look at them and give them advice. They didn't want to wait. And they were really accepting when they saw a physio who clearly knew what they were doing. And we have some amazing quotes from our patient participants who really liked the care they received. But I think something that's even more interesting is the promotion of health literacy, not just among patients, regarding that arthritis is not about bone on bone, but also among health professionals, that exercise is accessible to patients. And we consulted recently with one of our project team members, Associate Professor Christian Barton, who's at La Trobe, and he works with the GLAD program. And he's talked to us about research that's shown that language doesn't need to be a barrier to exercise, and high body weight or poor health isn't a barrier to participating in the GLAD program. Even patients who are frail and have low mobility can be catered to, because these programs can be scaled up and down to enable patients to access them. The only barrier, I think, was patients with really low cognition who couldn't understand. But we asked him about language, and he said even the patients who didn't speak English as their first language were able to see demonstrations of an exercise and be in a group environment and then come along for the ride and do the exercises and really enjoy that benefit. And they actually did quite well. So I think that health literacy is a really important thing, and it's across the spectrum of healthcare.
Yeah, that's fantastic. Great thoughts there. Your comment about they didn't care who they saw, as long as they saw someone who knew what they were doing, is something that it resonates with CHF. We've done research with consumers about this issue more broadly around pharmacy and prescribing, around scope of practice. And what we hear again is people saying, what I really want is good quality care. And I want to know it's safe. And I really don't care what initial qualification the person had. I want to know that it's safe and it's good quality care. And then, depending on the situation, I would make a choice to see someone, this person or that person. And what you're saying kind of reflects that too, that people are keen to see someone who knows what they're doing and they want to get care as soon as they can. Just before I leave, I've got one more question for you, which is from Melissa, which is, what would it take for knee OA to be managed as a chronic disease in primary health care?
Yeah, look, I think at the end of the day, it's likely to come down to valuing the role of primary care from a funding perspective. One of the reasons for our project is that our project is in the acute care setting, in the hospital setting, and we've got an overflow of patients who don't need hospital-based care. What they actually needed was care in the community, but that care's not accessible because it's not funded. So I think it really speaks to the broad spectrum of how care is funded in Australia for chronic disease.
Yeah, and I'm going to come to you about that now, Scott, because you mentioned that in your comments. And Ben's dropped a note in the chat saying that, people having access to allied health more broadly, including physio, is fantastic, but people can't afford it. So can you share a little bit more of, well, what would Medicare 2.0 look like for you? Particularly if we use this as an example, what could it look like for knee OA?
Yeah, look, it's a great question, and a question that we often ask each other sitting around the table discussing, like, what does Medicare look like into the future? And I think if you look at it, at the moment, Medicare is very much fee for service. So if you are sick, you go to the GP and you get your occasion of service, and you either swipe your Medicare card as a bulk billing or pay a gap on top of that. I think what we've got to do is actually look at different models of care, different modes of funding, and that might be a block funding such as the GLAD program. So it might be that instead of spending $25,000 to $30,000 on a total joint replacement, what we do is actually the Medicare will pay $2,000 or $3,000 for the non-surgical intervention as a block funding, and you get that that whole program free of charge or a nominal fee to go through the program of exercise, of weight loss, and education, and you know, enjoying, hopefully reducing that pain and dysfunction. So I think it's really looking at how can we fund it effectively and efficiently, and it's not fee for service at the moment. I think it's really looking at how we can actually get better bang for our buck in the system. And I think fee for service for this type of thing is not going to work. So I think block funding is definitely one area that you need to look at if you're going to reconfigure Medicare into the future.
And just while I've got you, Scott, there's a question about the National Preventative Health Strategy. So how the conversation we're having now might also link into the hopefully one day funded for implementation National Preventative Health Strategy. Do you see a link here?
Oh, definitely. I often always leave a talk or a discussion or a presentation with "I have a dream." And I think one of the biggest dreams is to actually have a funded preventative strategy, a prevention strategy for the Commonwealth, because you know, we've spoken about it for many years now, but we still haven't had a government that's been bold enough to effectively fund it. And I think this is a classic example where this preventative strategy, such as a GLAD program or such as just exercise and weight loss and education, can really effectively prevent someone going down the pathway of severe osteoarthritis and requiring surgical intervention. So I think this is a chronic disease that can be managed non-surgically and actually have better outcomes and a cheaper mode of delivery. And if you have a look at, like, say, our PBS, if someone is say got osteoarthritis of their knee and they're on multiple tablets of anti-inflammatories or you know, paracetamol and things like that, our PBS you know, pretty much covers majority of that cost. Wouldn't it be great if a GP or even a primary healthcare practitioner could actually prescribe something like the GLAD program, and you pay $3.60 for that as well. I think, you know, if you're really comparing apples and apples, that's what you're looking at, is, you know, you're taking away hopefully the requirement of some of these medications that are funded majority under PBS. Wouldn't that be great if we had a scheme that could actually do that under the prevention scheme as well?
Fantastic. Now, Margaret's got a question about a particular procedure. I'm just going to ask the panel if you'd have a look at that. And if you've got any information, I think she's looking for, does anyone know anything about this? If you know anywhere where she could get information about it, it'd be great if you could perhaps pop something in the chat and let her know. But I wanted to go to Pippa's question, which is about GLAD again. And she says, you know, as you've said, it's a really great program. And she's saying it's not only physios, but also fitness professionals could benefit from further education on this topic. And I think she's wondering, you know, how can we make these kind of programs available in Australia that educate more broadly, so allied health and others, in the benefit of these projects, and even get people involved. I'm thinking of things like Desmond and Daisy for diabetes too. There are all these great projects which do build health literacy, give people strategies for managing things. So I'm going to come to you, Danealle, and just ask, are you aware of that, or can you see a benefit in having people more broadly, allied health and others, trained in these kinds of approaches?
Look, I think that it's important to have as many people trained to provide these interventions, but it's really important that they're trained well and that they're safe. So I think that I'd probably urge a little caution that we don't want sort of people untrained delivering health advice to people with chronic disease. What we want is really high quality healthcare. So I think that that's probably where I'd land with that.
Yeah, great. Thank you. Thanks, Danealle. Phoebe, I've got a question for you that's come from overseas for us. So from one of our overseas folks, Mihak Fatima, thanks for you joining us today. And they're asking if there is any significant assessment test that can differentiate whether the knee OA can be cured or managed without surgery. I mean, where would they find information about ways to do that?
I mean, I guess the first thing to say is, as Scott said earlier, that joint replacement surgery is absolutely life-changing for some people. And we don't want to be heard to be saying anything different to that. But I think what Mihak is asking there is, well, how do we work out who those people are? And we know that imaging findings correlate very poorly to what's happening within the joint and the degree of severity. So we definitely don't want to be treating the scan rather than the person. So, I mean, I think it's important just to take a very thorough approach to the assessment, not only the history and the examination, but also really thinking about how much it's impacting that person's function and what they've already tried. So I can imagine, somebody coming to Danealle's program who's already engaged in a lot of these things that we're talking about in the clinical care standard and experiencing significant disability with their knee pain. That's quite a different situation to perhaps somebody who's earlier on in their journey. I do know that there's some research saying that there are, certain ways to try and predict, I guess, people who are more likely to benefit from surgery than others. But that's probably something that a surgeon would be better placed to answer. But yeah, I guess that individualized assessment, I think, is really important, and exploring with people what their expectations of surgery as well, I think is a really interesting conversation. And somebody, I think, in the chat has talked about rehab, and I think that's a really important conversation to be having, because for a knee operation to go well, you've really got to commit to significant rehabilitation afterwards. And, people really have to understand that.
Thank you. There's the question about, Gwen, thanks for your question about the medical curriculum needing to be updated. I'm just going to get a quick response from you. So, folks, we've got a couple more minutes before Melissa will do a bit of a wrap up. If you've got a last question, you can pop it in there. Someone might see it and be able to respond to it, but we might be able to manage one more. But the one I wanted to ask you, Scott, is what about also physio curriculum? I mean, how important do you think is that the curriculum for whichever discipline it is are up to date with these kinds of changes?
Yeah, definitely, Elizabeth. I think, spot on. I think I always come back to, the message has got to be consistent across the whole, the whole sphere of medicine. So that means physiotherapy, it means GP, it means surgeons, it means dietitians, it means exercise physiologists, it means occupational therapists. And I think what we really need to ensure, and I think hopefully Phoebe and the great work of the Commission is going to give us a standard that gives us the consistency of our language, the consistency of our education, the consistency of our testing, the consistency of our prehab, the consistency of surgical intervention, our consistency of what surgical intervention there will be, and then the consistency about the rehab. So I think it's not just about one discipline. I think it's about the whole health system, and this is where health leadership is a key area. And I think osteoarthritis is one area where health leadership of us all needs to be highlighted and ensured, so that the governance is right, that the education of our next generation coming through, but also currently that are here as well. And I think the Commission's standard is a great step forward to ensure that we're all talking the same language, that we're all talking the same pathway, and that we can ensure that the consumer has the confidence in the system that we believe that needs to be. So then that we can put the pressure on the government to actually look at how do we actually fund it, and how do we get the governance structure right to ensure that the consumer, the patient, has got access to the right care by the right person at the right time and by the best practitioner available. And I think that's not just surgical all the time, it can be non-surgical intervention as well.
Fantastic. Look, it's been a really great conversation. I'm going to pass across to Melissa in just a moment, but I'd like the panelists to swipe right, because now what all the people on the call are going to do is they're going to use their emojis to make you feel good. 3 panelists, so at least to use at least 3 different emojis, folks. So if they swipe across, you can show them all kinds of things to just have a simple way, as you would at the end of a meeting by giving people a clap, to say, well done, fantastic. Mahak's dropped a heart in the chat, love it. Anything you'd like to do to share and say thank you for them giving up their time for you this afternoon. I hope you've learned something. I certainly have. And now I'm going to throw across to Melissa to wrap up. Thanks, Melissa.
Thanks very much, Elizabeth, and to all the panel members and participants. It's been wonderful following your comments and questions in the chat. And I'd also just say that Professor Bronwyn Fredericks is still there. I wasn't sure if you were going to be able to stay for the whole webinar, Bronwyn, so I might, if you don't mind, add you to the list of people to make some final comments if you'd like. As you know, we're doing a story out of this for Croakey tonight, so I thought I'd just whip around the panel and to Elizabeth and Bronwyn as well, and ask all the participants to put it in the chat as well. What's your sort of key takeaway from tonight? If you had to write a headline for us at Croakey, what would it be? So we might just go through the panel in order. Phoebe, what would your what's the headline you'd like to see us publishing, or that's on your mind?
Oh, I think just echoing what Scott said at the end, around all of us speaking the same language and promoting the same care for patients, because otherwise it's terribly confusing and I think people get lost in that system. But if we're all talking the same way about OA of the knee, I think it's going to streamline things and help deliver better care.
Thank you. Danealle.
Well, I'd like to acknowledge that the clinical care standard for knee arthritis is a really excellent resource for guiding evidence-based pragmatic care. And this shows us where care should happen, by whom and when. And it's really sensible. So I would really like to acknowledge the Commission's work on putting that together. It's a really good resource.
Thank you. We'll all be looking forward to seeing the updated version on Thursday. And I've put a link in the chat where everyone can access it as well. And the Commission has also compiled a stack of resources related to this discussion and the standard, which I think will be very helpful. Scott, what's your headline? Give us something strong. And
okay. I reckon all Australians have access, equal access to best practice management of osteoarthritis care.
Thank you. Now I'm just going to drop a little alternative version in there. I saw Patrick Tobin put a comment in the chat, which I think gets to some of the sort of real politic of what's involved in some of these discussions. One of the problems, he said, is that the Commonwealth is being asked to fund new programs that save the state's money. This needs to be addressed as part of wider health and funding reform. So it's a very important underlying issue that is a barrier for so many health reform discussions. Elizabeth, what's your takeaway?
Well, I love the comment that you made in the notes about, you know, high value care being overfunded and low value care being underfunded. And I think that people will vote with their feet if they understand what the value is that they're getting. So for me, it's something around the highs and the lows of you know, knees, and how we can educate the public to understand what best practice looks like so they can go and get it.
Yes, it's such a shame that Nigel wasn't able to join us tonight, and I really encourage people to read his article, because when we spoke to him ahead of the webinar, we asked if he was an outlier amongst surgeons. Obviously, surgeons' voices on these issues are very important, and he said he might have been once upon a time, but not so much anymore. So that's encouraging, because at the end of the day, a lot of these questions come down to, as we've talked about, financing and funding, who gets paid to do what, or not paid to do what. And that's, I put a comment in the chat about social prescribing as another way of looking at health reform as well. You know, outside of healthcare systems, health reform can happen. Bronwyn, can I throw to you? Would you like to end this up?
I would say consistency is key in managing osteoarthritis in the knee. You know, consistency of care, have all talked about consistency of care, consistency of message, and consistency of funding, you know, in terms of how funding is managed. And that came across really clearly to me. I mean, I read things at times and it's unclear at times, but consistency for me really is key. And it speaks to what Phoebe said in the beginning, just before, in terms of the wrap up around the messaging across and, you know, having everyone on par. But I just want to thank the speakers tonight for your contributions and for preparing ahead of this evening to be able to talk to the topic and give us lots of information and answer questions that come up. And also thank all the participants as well for coming along. If we didn't have people that came along to this, it wouldn't be as good, and we wouldn't have the dialogue or the interaction or questions put up, but also not questions just on the night, but questions ahead of time sometimes that people want us to look at. And also finally, the sponsor, the Australian Physiotherapy Association too. It's fantastic that organisations sponsor such events, you know, for the public good and for the better health of Australians. And I can't stress that enough. If we didn't have the sponsorship and the support of organisations like we have tonight, we couldn't do these kind of events. And speaking of the type of events, I just want to remind people that we will be having another Croakey Live in September, which will be coming up to the 1-year anniversary of the Voice referendum. And I just encourage and I plug for that I'll be co-hosting that night with co-chair for Croakey, James Blackwell. So we'll be doing that. We will have some guests on, just firming that up, but it will be in September. So look out for announcements in that. Thank you. Back to you, Melissa.
Thanks so much, Bronwyn and everyone. And I guess that's time for some people to go home or go and make some dinner. The Croakey team will stay online for a little bit if anyone wants to have an informal chat. And again, just thank you for your time. It's really terrific to be able to have this conversation, and it raises so many wider issues for us as well.